Okay, I'm Dr. Michael Pasquale. I'll tell you a little bit about my history. This is one of my registered nurses who's a ketamine nurse, I call her. She's been doing it quite a while. Um, my history is that I was originally a general surgeon, trauma surgeon, trained at NYU, and actually spent a year there. I then went over to at Hilo Hospital, where I became their trauma surgeon for a few years and decided I want to be a trauma surgeon. So I went back and I did plastic and reconstructive surgery. But more importantly, I did a microsurgery fellowship in peripheral nerve, which dealt with a lot of chronic pain patients. We would rewire people's faces, all types of things like that. And that's a young man's sport. I'm a little older now, so I don't want to be in the OR for 36 hours at a time. And I've been practicing here in Hawaii for about 40 years. Half my practice now is wellness, anti-aging medicine, sort of like a ketamine clinic, some other things we do, some other therapeutic things we do, and about half of it's cosmetic. So I don't do the big surgeries like I used to. I do like facelifts and things like that. And I run these, we also have a stem cell clinic. I've always been kind of cutting edge and I like these newer things. And my involvement with ketamine started really in 2014. I was one of the first ketamine providers really anywhere, first one in Hawaii. We started the ketamine clinic of Hawaii. And my experience was I had a friend who was going over to UH for electroconvulsive therapy with Dr. Barry Carlton about once or so a month. And it actually worked for her. It was actually working very well. But she wanted to try something new. And I had read some papers about ketamine for treatment-resistant depression. And I said, "You want to give it a try?" And she said, "Yeah." So I'm very familiar with the drug ketamine as a surgeon. We use it all the time as an anesthetic, and we use it in children, pediatrics, everything. So I'm very familiar with the drug. So we tried it, and unfortunately, it didn't work because I didn't know how to dose it properly. I pushed it like I would uh, a ketamine push for anesthetic, and that kind of freaked her out. She didn't want to do it anymore. But anyway, since that time, I became a lot more educated in ketamine and how to use it, and we developed some of our own techniques on, depending on the type of patient it is, and our own protocols. I'll get to that in a little while. But first, what is ketamine? All right, ketamine is a drug that's been in use, I think, since it was invented in the 1960s, I believe, and it was invented by Calvin Stevens. He was a chemist, and he started testing animals, and eventually it was used in humans in 1964. And it was of great use during the Vietnam War because the drug itself, it's a disassociated anesthetic. It means the person doesn't care. They know what's going on around them a little bit, or they can go completely unconscious depending on the dosage. And the good thing about it, the medics in Vietnam could use it because they didn't have any problems with the airways, which with any of your narcotics or some of the other anesthetics you use, you always have to be very careful of airways. And in fact, ketamine is a bronchodilator, and so I think they've used it in cases of status asthmaticus too, possibly. I'm not sure about it. It seems I heard something about that. And in the 1970s, it got approved for medical use. And like I said, as mentioned, I mentioned it was used in soldiers of the Vietnam War, these terrible gunshot wounds. The medics would load them up with ketamine in the field before they get on a helicopter to be shipped back. And in the 1980s, it started being spread around as regular medical use and as an anesthetic. About that time, it also became a party drug, fortunately. And people would snort it at parties or inject it. And they go into what they call a ketamine hole. It's called vitamin K. And my personal opinion is it's a terrible party drug because you're out of it. I mean, LSD was a much better, at least in my generation. Um, so in the 1990s, there was a lot of abuse of Special K on the streets. And in the 2000s, I guess there became better drugs to use. as a party drug, and it kind of waned by the uh, it went by the wayside because it just wasn't that much of a party drug. Although some people still did it at raves and things like that. And around 2000s, in the 2000s, um, people began noticing and studying ketamine, which elevated depression on depression patients and eliminated their suicidal thoughts. And they started formal studies around 2003, 2004, and it ultimately showed to be an excellent treatment for as an alternate treatment to depression, and especially the treatment-resistant type, where the SSRIs, the other antidepressants weren't working. So, as I said, that's how I got started in it, with that one friend of mine. And since that time, we've done hundreds of patients. Um, and it's been almost a miracle drug for some people. The present uses, we use it in our clinic. I'll just go with our clinic. Uh, we use it for depression, which we usually require a referral. I'm not a psychiatrist. And it's very important for a patient to have a solid diagnosis of depression. Um, and if they don't, you can get into trouble. One time, I don't want to mention names, but they were doing a study over there, and they were using ketamine at the university psychiatric department, and their study limited on the amount of drug they could use. And what happened was they had this one patient, and the psychiatrist felt that maybe they need a higher dose because it wasn't working for them. And they sent the patient to me and said, you're in private practice, you can give them a higher dose if you want. So, okay, we'll give it a try. And after one or two sessions, it was just obvious that the patient was not responding at all. She was making these weird bird sounds, like chirping like a chicken or something. And so I sent her back. I said, look, she's not responding like I usually see these patients respond. And they took her down for electroconvulsive therapy, giving that a try. And my friend, I said, how did who had electroconvulsive therapy, I said, how'd your ECT go today? And she told me, it went pretty well, except for the fact there was some lady next to me chirping like a bird. So anyway, I had a good laugh about that. I teased the doctors about that. But they went back and reevaluated her, and she was a schizophrenic, which you don't want to give ketamine to a schizophrenic for, as you can imagine. That explained a lot of her behavior. Can you guys hear me right? Yes?
Yeah, we got a thumbs up.
Okay. I just want to make sure because it's very quiet over there. Safety considerations. Well, let me go back into what the uses we use it for. We use it for severe depression, and that involves an hour-long treatment. We slowly drip a dose in based on their weight and other factors, such factors as if they've used party drugs before. Those party people tend to be able to use a higher dose before it really affects them. And it's really a clinical evaluation as you go along. You see how the person's reacting. And it's IV ketamine. We pretty much almost only use IV ketamine. And the good thing about that is that you can titrate it depending on how the patient responds. And with the IM injections and the nasal spray and the lozenges, you don't know how much the patient's getting. And once you give the IM injection, that's it. It's in the patient. You can't control the dosage. With the IV ketamine, intravenous ketamine, you can regulate how much they're getting and how fast they're getting it. So we use it for depression patients, which is probably the more common use. But getting back to my experience as a microneural surgeon, we call it microneural surgery because that's what we operate on, was nerves, and chronic pain patients. We use it for a lot of patients with chronic pain. CRPS is one of our bigger uses. It's a longer treatment. And there we've seen some miracle patients that it's really changed their lives. And I'll get into that in a minute. I've tried it on a few patients for addictions, such as alcoholism or drug use, and we've had quite a bit of success there as well. Um, we don't do the addiction counseling, so I don't see a lot of those patients, but the ones I have worked on have done fairly well. Um, what else am I missing?
CRPS, PTSD.
PTSD. So we've done quite a few soldiers with PTSD who have benefited as well. Not everyone's going to benefit. It's like any other treatment in medicine. But I would say 85% of the patients that we treat have significant benefit from it. And as I give you an example, I had my nurse bring in a couple of charts. Um, I'll let her talk about this case, and I'll talk about the other case. Here was an example. This was a 65-year-old Asian female from China who didn't speak a word English. Her children did, and they brought her in because they read or come up with information that we were treating chronic pain. Now, this was a woman who came into our office, hunched over. You couldn't touch her skin because she was in so much pain, and she would just wither back. And she could hardly speak. Her family told us that she spent most of her time in bed in the fetal position. So, I don't have an exact diagnosis on her. It was some form of CRPS. And of course, with chronic pain comes depression. So she definitely had an element of depression with her. And we did both pain scales and depression scales on her. So after the first session, which was an hour-long session, she left and I'm sorry about that. That's the wife. And she left the session and she was moving a lot better, we noticed. And when she got home, her family told us that she slept better than she had before, which was encouraging to hear. This woman was very sad to look at. I mean, she was just grimace face. She was very much, like I said, in the fetal position, could barely move or walk. And so she went through several more treatments, but we do a series of 5 usually on this patient, 5 treatments. She actually walked out of here and she was smiling and laughing. And her family said she hadn't done that in years. So that's probably my best example of turning a patient with a pain syndrome around. And you want to talk about that?
Yeah, this patient, a really kind of similar story in some ways, and it's just the exact reason why I love working with ketamine so much. It's so rewarding as a healthcare provider to feel like you're really making a difference for these patients. He was a 61-year-old male, and he had chronic pain syndrome. He had depression, he had anxiety, PTSD, tons of trauma. That started when he was like 3 years old from abuse as a toddler, and he just suffered his entire life. Was in 10 out of 10 pain, had a spinal cord stimulator, was on all kinds of opioids, nothing worked. He tried all the SSRIs, all the traditional depression treatments, tried therapy, tried everything. It just wasn't working to like give his brain that reset that he really needed to like get a new start and get ahead of all the trauma and all the pain. And it was very linked together, just like Dr. Pasquale's patient, where if you have chronic pain, it's really depressing. It can cause anxiety. And a lot of times the trauma can cause that chronic pain to be a lot worse too. He was tense, he couldn't sleep ever, his appetite was awful, he was super skinny, he was very defensive, really shaky, never smiled, so nervous, this guy. And we did an hour-long session every day for 5 days. And by the end of his treatment, his depression was significantly better. Pain went from a 10 to a 1 without any opioid meds, no PRN meds at all. His spinal cord stimulator was off, and he got really teared up at the end. And he said, "This is the first time I've slept all the way through the night. I haven't taken any PRN meds. I never thought I would get like this." He said there's the first time he hasn't been suicidal since he can remember, and feels like he has the actual chance now to potentially enjoy his life. It's really, really rewarding to get to see.
It is rewarding. I mean, I was a big reconstructive surgeon. I used to put people's hands back on. And you get pleasure because this person comes in with an amputation, you're able to restore some hand function. It's not 100%, but at least they have a hand that's working. This stuff has amazed me in terms of the amount of improvement. I mean, we brought people from crazy low depression to laughing and giggling, and it's a miracle to see. Like I said, though, I don't mean to oversell it. It's not. It hasn't worked for every single patient, but most patients it has. Um, there are three routes that are ketamine. I want to speak a little bit about this. And I read all the papers. Some of them are good, some of them are bad. Mine's from experience. I mean, since 2015 is when I really started getting into treatment. I have a lot of clinical experience. Um, the three main routes of ketamine administration are number one, the IV therapy, which I think is the most effective, and I think most of the literature reflects that. Nasal spray, which I'm still not sold on it. I mean, there's some people we've had in our practice that have used it elsewhere and said it was somewhat effective. Um, and then there's lozenges, and then there's the IM injection. Um, Ease of use, the IV ketamine, you have to have a pretty clinical setting to use it. We have the patients on a monitor. I'm critically care trained, and because it will get their blood pressure elevated or their heart rate. Uh, they'll get tachycardia, and if it gets crazy, you have to control it. Very simple to control the betalol, hydralazine. You should also have IV Versed in case they have an anxiety attack on board. And like I use registered nurses because they're familiar with medications. I'm always around when they're carrying on. They stay in the room with the patient. The IM injection, I think, is a lot more safer, but I don't think it's as effective. And like I mentioned earlier, the control you have. Maybe I'm a control freak. I like to be able to control how much a patient's getting. Once it's in the body, it's in there. The nasal spray, as I said, I've had patients in here who said it's worked for them. But part of me says that the nasal spray makes them feel good for a little while, but it doesn't institute the changes which I'm going to get into in a minute, which is the neuroplasticity. If I gave somebody a shot of heroin, they're going to feel great. Oh, my depression's lifted. But that's not what we're after. It's not just the feeling of feeling better. What we're after is rearranging the synapses of the brain in neuroplasticity. And I think you have to have a certain blood level to obtain that. That's why I'm a big believer in the IV ketamine as opposed to the other routes of administration. Now, why does ketamine work? Okay, so everybody knows it's an NMDA receptor agonist or whatever. And I mean, that's all well and good. I think, yes, it like the SSRIs, it does mess with neurochemicals a little bit. I don't think, in my personal experience, that is the reason why it helps all these conditions. All these conditions, whether it be CRPS, whether it be PTSD, whether it have alcoholism, whether it has depression, these are all internal brain problems. This is the way I think of it. So in the brain, we have millions and millions of synaptic connections, and they get fixed in a position, whatever that connection is. And it's really complicated. I don't know if anybody can perfectly describe it, but I can't help you visualize it. So you have all these connections of synapses, and they get fixed in this location. And the reason why the body does that is because it wants to keep you in a steady state, homeostasis. That's why our blood pressure always stays the same. That's why. The problem is with these people that are candidates for ketamine therapy is they're stuck in an abnormal state. Well, ketamine increases neuroplasticity. It allows these connections to loosen up and reform. And that's what I believe is the main effect. You're actually, for lack of a better term, rewiring their brains or allowing their own brains to rewire themselves. And I think that's the modality of why it works. I don't think it's the neurochemical effects.
So
Well,
have you seen impact in just one session? I mean, it sounds like you did with the elderly woman,
yeah,
but
I mean,
do you
we do
expect?
a little bit. I mean,
Yeah, usually, I mean, with the patient that I mentioned, it's like a little bit better the next day, maybe, and then a little better. And then by the end of the week after the 5 sessions, that's where like the big,
And then
like their depression score may go down a couple of points, or their pain scale may go down a couple of points, which is a noticeable change. but it usually takes about at least 3 sessions, I've noticed,
Mm.
to show a strong effect. And and there's different ways to do it. Some people do it like twice a week for 6 weeks. I don't. I like to do it one right after another because I'm a big believer in this neuroplasticity. So we keep. I don't know. Maybe I'm too much of a
Do they, yeah, do they come
concrete
back?
surgeon and think in terms of mechanics, but
You just like to get it
you
done.
hit those neurons and
Yeah.
you hit those neurons again, and eventually they're going to come loose and reform.
Yeah.
It's
You're
not
a
the
surgeon.
condition.
You like to get it done. But when do you when do you bring them back? If they're fine, they never have to come back, or do you bring them back in a month?
Okay, so it actually gets into the way we price our product, so to speak. We will give a package of 6, and then we give them a discount because it helps them out financially. But we usually use 5, and we don't. Some people I never see again. They're still. I had one of my medical students call up, follow up, and they say, "Oh, we're still fine. I don't need it anymore." So that's great. But then some people do require a a touch up treatment. They may not need the full 5 again, but they might need, like I said, a touch up, a one time session. They always ask me, well, when do I have to come back for that one time session? I say, you're going to have to tell me. You'll know when you're going back down that path to depression or pain or whatever.
Got
So I'd say about half the patients will come in for a touch up. I don't have the numbers on the frequency. But I usually don't see any patients for like 6 weeks later at the, some people 6 months later. It's like that. It's very wide variation. Um, yeah. So there you go. There's a lot of ketamine clinics popping up all over the country now because it's profitable. Um, we've had, and the same thing's happened with my stem cell clinic. It is a profit center for doctors, and everybody wants to get into something new. And it's you have to be cautious where patients go. I mean, there's very good stem cell centers, there's very good ketamine clinics, but it varies. And I think the patient has to take some responsibility on investigating what is really legitimate or not. And there you go. And that's my talk basically. I'm welcome to take any questions you have.
We have lots of questions.
Okay, go
Let's
for
see.
it.
Yeah, so it's funny because we were sharing what we had heard about ketamine beforehand, and a lot of things that people said were true, even though we were just trying to get, even the wild and crazy stuff out there. So anyway, Colleen says you mentioned that ketamine isn't recommended for schizophrenia. Are there other diagnoses where
Oh no.
depression?
The ones that don't do well on ketamine are severe and pure anxiety disorders.
Ah,
They freak out, and we've had them happen. Someone like a schizophrenic or psychotic, you don't want to give ketamine to. And I've had experience. One, like I said, was a misdiagnosis for the university. Wasn't my fault. And then there was one that came in. I had a couple of patients that, oh, and I asked him, is this mainly anxiety you have, or mainly depression you have, or whatever? And they said, oh, it's anxiety. And I'm thinking PTSD. And then once I got a clear diagnosis on it, was a pure anxiety disorder, and they didn't do well.
hmm. So let's talk cost. Do any insurances cover it?
No,
All right. So what is your plan of 6 cost?
we're not cheap. And all the competition is out pricing us, which is okay. I mean, whatever they want to do. Um, our cost, so 6 treatments, it's $4,000.
Okay.
Um, I do give people breaks all the time. Like, I'm kind of one of those bleeding heart kind of people that, a guy comes in and I'm just, well, I know we can help him. Let's just do it. Let's just do it. So I'm not like totally money hungry. I like money like everybody else, but I do care for patients a lot. And each individual treatment, 750. I think the national average is about the same. We've seen some nurse practitioners here that are doing it for like $300, um, which is okay. I just hope they have the proper monitoring equipment and all that stuff. And a lot of people choose us because they can see we're very clinical. A lot of the other clinics, they tend to have more on the foo-foo side. You know, how should I put it that way? They try to make it like a medical spa. And some people do therapy during the ketamine session, which never makes much sense to me because they don't even remember half of it. But I guess you could delve in deeper or something. I don't know. And if they want to bring in their therapist, they're more than welcome to here. But that's one of the differences between our clinic and a lot of the other popping clinics that are popping up.
So if it was a party drug, how come it's not in an oral form other than the lozenges?
I don't know. I don't know. I don't know why it's not in the pill form.
Hmm,
Maybe probably the stomach acids destroy the chemical structure of it.
interesting. Okay, and where is your clinic in Honolulu?
Yeah, so I don't know if you know where the Kaka'ako area is, on Ala Moana Boulevard, right in front of the medical school.
Hmm. Oh, in the Gold Bond building?
Yeah.
Oh,
Hi, Dr. Pasquale. My name's
Hey.
Robin Martin with psychiatry. I trained at Queens with Dr. Liu and using ketamine. First, I just want to say thank you for bringing up
Yeah, very familiar with your group. Yep.
thanks for bringing up this topic and thank you for treating patients in the community. Um, yeah, I in my work training at Queens, I saw a lot of really great results, with kind of with using ketamine in kind of the post-surgical suite. Usually these would be patients kind of um, who couldn't tolerate ECT or preferred not to use not who are concerned about the side effects for ECT. And I personally felt like it was really underutilized in the hospital because I saw
It is.
results that were on par with ECT. Um, I became after I graduated, I attended a psychedelic psychotherapy
Sure.
kind of postgraduate training, and during that training, I got to experience ketamine myself, and I really got to appreciate its profound psychedelic properties, and in that training, we there was a lot of attention kind of placed on kind of preparation for the session for
Right.
kind of the set and setting of the session, kind of utilizing music, eye shades, and making the patient really comfortable, and then kind of integrating that session in the follow-up. So um, I'm curious if you require or if you guys are trained in that kind of delivery of this care, or if you kind of
Yeah,
encourage
Katie
or
is, and
I
we've
can speak to
actually
that
changed a
actually.
lot of our room around to
Yeah, because
very, very comfortable, proper colors in the room, proper lighting. What do you call it? The small stuff.
yeah, how essential oils going. I agree. It's super important just for them to feel like they have a safe space to like potentially have trauma come up or like be facing some of these really tough feelings. And ketamine, the dissociative effect can be so overwhelming for people just in general for some. So we did put a lot of intention in our ketamine therapy room. The walls are very natural, like stone type color, and then there's green in there, soft blankets, the essential oils, and sensory grounding kits. So like something soft, something that smells good, and just if they get
We have
overwhelmed,
headphones and
like
all that.
the noise canceling headphones, I go over all that with them too prior to start and just say like, ground yourself back in your body and feel, this sensation, something soft, something pokey. Smell your favorite smell, like we talked about what essential oil they like, pair with that lemongrass, and just like ground yourself with your senses there too. So that's important, and them just
nice.
feeling like there's some intention in the space. So we definitely put a lot of mindfulness into it.
Nice,
That's
nice.
that's been that's been a recent change. I mean, Katie's convinced me of the importance of that. I'm a lunkhead surgeon. I'm more concerned about the clinical aspect of these things and the proper use of medications. So
I've
we've
almost
definitely changed our protocols to accommodate
That's cool. Yeah, I've really noticed that the music plays a critical
that.
role in the experience. Do you guys kind of like do you invite patients to bring their own music, or do you curate playlists for them
We have
to?
both, whichever, it's all up to what the patient wants. Right. I have a quick thing I have to run out and do. I'm going to let Katie go over that with you real quick. I'll be right
okay.
back.
Let me
Okay.
Yeah, I'd be happy
okay.
to. So during their initial consultation, if they're interested in moving forward, usually I'll do a brief summary, or if they weren't interested yet and they schedule like the 5 days in a row, I'll do a phone call prior with them and just say, hey, this is a little bit of what you can expect on your first day, and we have all week together, so we'll figure it out as we go. But things to bring with you would be like a soft blanket, fuzzy socks, anything that makes you feel comfy, like a stuffed animal or just like a little safe item of your choosing. If you have a favorite essential oil, whatever, noise canceling. Headphones is really important. We have them here if they don't have their own. But I just kind of go over everything that we talked about when it comes to like the sensory experience and like what makes you feel safe and cozy and comfy and like what they should bring with them. So we've gone over all of that already. And then when they arrive that day, and I've done all their patient history, doc and I have determined the dose. I've reviewed everything. They come in and they fill out a Montgomery Asperger Depression Scale, is the one that we use to monitor their depression and anxiety monitoring throughout the week. So they do that before every session, 5 days in a row. For the depression patients or the PTSD patients, that measures anxiety and depression symptoms. Then there's a total score, and at the end of the week, we look at kind of their progress, whether it went down or up. I can talk to them about it, at that point. And then for pain patients, we have a brief pain inventory scale that they fill out before every session too. So usually I go in there, say, hi, what's up? And, build some rapport with them, let them know what they can expect. I say, go ahead and fill out your scale. Let me know if you have any questions, but when you're done with that, take your time. I'll make sure you're cozy. We're going to start at IV. We're going to pre-treat you with some anti-nausea meds. And then when you're comfortable and you're ready to get started, we'll get your music set up, make sure you're all good to go. And I explain to them, I'll be in the room with you the whole time, there for support if you need it, and making sure that you're physically safe. And then, once they're ready to go and we've gone over everything, what they can expect, then we start the ketamine infusion. And then once they're done, they're in a recovery period. That the length of that kind of depends on the patient, how long they need, but usually at least like 30 minutes before their vitals are back to baseline. Mentation is closer to baseline, and then their chosen person comes to pick them up. I discharge their care once they're steady and clinically stable to go. And it kind of looks like that's the basic structure, but every patient's different on how many questions that they have, and if I feel like it's like necessary to chat a little bit more to build that professional rapport and stuff like that. It just depends.
Okay, we've got a lot of interesting questions here. Is it common to get panic attacks during treatment, like feeling out of control?
Occasionally, not very often.
Not really.
We resolve that with a touch of Versed, which is titrated to their anxiety, like a 0.5 milligrams push.
Right.
But I
I've
don't know,
only
remember
seen
you
it a
using
few
it. Yeah.
times. No, I've only in my whole couple years of doing it,
Yeah.
I've seen it a few times. And usually, I mean, just as the person sitting in the room, I try to be aware of their body language. Like, are they getting really tensed up? Do they seem overwhelmed? Are they breathing faster? Like, I can, even though they can't tell me because they're on ketamine, I think some patients get worried. They're like, I don't know if I'm going to have words in the moment. But you can pretty much tell if somebody's getting overwhelmed. And that's why the IV is great. So I would slow it down, let them kind of come back to earth for a minute and say, hey, you doing okay? Like, do you need to take a break? Do you need to pause? Like, what's going on? And then I've only had it a few times happen where they just have such unmanageable anxiety that they do need that IV per se. But usually, if you slow it down and give them a minute and let them know, you're all good, they're good to go.
More commonly, interesting enough, we have patients that complain they don't really feel it enough. And the way I've been handling that, which seems to work quite effectively, is we'll give them a very slow push of like 5 or 10 milligrams of IV ketamine, which brings up their blood level and they go where you want them to be.
And then they feel it.
Yeah, I mean, I think, yeah, it's interesting.
That makes sense. Okay, so Renata asked, for those who are smokers or have had nasal septum destruction from cocaine, are those contraindicated? I guess
No,
me.
smokers would be. Their breathing improves
Oh,
with
okay.
ketamine. Um, as far as nasal septum, not
Maybe
really.
so.
I don't
Nasal spray.
I don't think it would affect it at all.
All right. Okay, so we have a little bit of discussion on the neuroplasticity because Renata also asked, does it contribute to brain cell growth and development? And Robin says that studies show ketamine increases neuroplasticity, increased connections between neurons, and can reopen the critical window of learning. Ooh, I
Yeah,
like
it
that.
does. I mean, the studies seem to, and most practitioners who have studied this in terms of the anatomy and so forth, think it does actually increases the number of neural connections.
Mm, all right.
Dr. Pasquale, I'm curious about your protocol for doing 5 sessions in 5 days. Um, my understanding is that the neuroplastic window for ketamine is maybe lasts somewhere between 2 days and 2 weeks. So in my mind, it makes sense to repeat sessions in that window of time so you can kind of leverage the kindling effect of ketamine. But I'm wondering if you found like you saw better results doing it that frequently.
Yeah, I've done it both ways. And sometimes I'll do like, as you probably know, that either protocol is acceptable. I mean, within the standard of care. I've just found in my experience that we do the five. Now, sometimes somebody has work schedules or things like that. We'll do three a week, two a week. I don't think I like one a week. I mean, that's total based on my clinical observation over the number of years I've been doing it. Um, what about you? Do you do?
I usually do weekly, sometimes twice a week, but I haven't done it. I haven't really tried it more frequently, so I'm kind of intrigued by your
Give it a try. You'll
yeah.
see. Yeah, I think my own theory, which is based on observation and clinical experience, is that the patients that we do it frequently with, like 5 sessions in a row, I think they get a stronger effect. That's just my personal observation. I've done it both ways. Um, I, I haven't seen any data to contradict that.
So last question I've got is, how do you protect yourself legally during the disassociative experience? And I think that's, people can accuse you of anything.
Yeah, how do
She's
you
in the
protect
room.
yourself legally? Um, so we have the patient fill out all the consents before starting treatment, in terms of like what they can expect. All their consents are done. And then, I mean, myself as a nurse with psych experience, I always am careful to like have that professional boundary of rapport.
We also have cameras in the room.
And there's cameras in the room too.
All right, there you go.
But just
All right.
being
Well,
intentional about what, you say and putting those boundaries up if they try to push it a little bit, it kind of comes with experience, I guess.
So as you can see up in my corner,
oh, yeah.
not the exam rooms, but when I do consultations in here, and we have cameras.
All right.
But
Well,
for we follow protocol too. Like I never am in the room with a female patient without a female nurse
right.
or chaperone of some sort.
Well, thank you so much. This was very interesting. And by my metric of quality of presentation, which is how many questions are asked, this is very highly rated. So a lot of interest in it, and I think you have a future partner there in Robin. Very interested in it. So yeah, so thank you very much. And I see the thank yous coming in on the
Well, I'm
chat.
just a little country doctor trying to do a job.
Yeah. So thanks. Next.